It is just for future reference. So, yes, this is actually record गरेर कस्तो हुँदो रहेछ रिभ्यू गर्नको लागि
Okay.
अब यो चाहिँ हाम्रो फोर्थ सेसन हो हामीले चाहिँ उसमा यो पहिलेदेखि स्टार्ट गरेको सेसनहरू सबैमा चाहिँ अब जेनरल इमर्जेन्सी मेडिसिन टपिकहरूको अलिअलि ब्रिफ डिस्कसन गर्छौँ अनि सो द्याट मोस्ट अफ द टाइम्स पर्पोज भनेको चाहिँ पछि गएर एमबिबिएस सकिएपछि अब जहाँ गएर काम गर्ने हो त्यहाँ चाहिँ युजली मोस्ट लाइकली हाम्रो सबै एमबिबिएस ग्रेजुएट्सहरूले चाहिँ के अरे इमर्जेन्सी डिपार्टमेन्टमा काम गर्नुपर्ने हुनसक्छ हेलो अनि अर्को चाहिँ प्राय जस्तो ठाउँमा चाहिँ अब जस्तै प्राइमेरी केयर सेन्टर जस्तोमा गएर काम गर्दा पनि इमर्जेन्सीहरूसँग डिल गर्नुपर्ने हुनसक्छ त्यही भएर नेपालमा भएको रिसोर्सेस अनुसार कसरी काम गर्ने भनेर प्रिपेयर गर्नलाई हो मेन इन्टेन्सन चाहिँ कोलाबोरेसन फर इमर्जेन्सी केयर नेपाल भन्ने हाम्रो एउटा अर्गनाइजेसन छ त्यसकै थ्रु हामीले यस्तो प्रोग्रामहरू गरिरहेको हुन्छौँ Once again, please join slido.com मा 3769638 कोड हालेर आजको सेसनको गोल्स भनेको चाहिँ अब कुनै पनि पेशेन्ट इआरमा आइसकेपछि सस्पेक्टेड ओभरडोज सस्पेक्ट गरेको छ अथवा चाहिँ पोइजनिङ केही छ भनेर सस्पेक्ट गरेको छ भने कसरी त्यसलाई सुरुमा कसरी डिल गर्ने अनि त्यसको अब हामीले टक्सिड्रोम्स भनेको छ that's a group of clinical presentations which have like common presentations and common treatment approaches based on what the patient has been exposed to and some principles of decontamination अब डिटेलमा हामी डिस्कस गर्दैनौँ अनि ल्याब्सहरू के अर्डर गर्ने अनि मैले नै देखिरहेको छैन लास्टमा के लेखेको छ भनेर रोल अफ एन्टिडोट्स थ्याङ्क यू अनि त्यसपछि मेबी मेरो कन्ट्रोल्सहरूले गर्दाखेरि होला first of all, so like in any other emergency, when a patient presents to you in the ER, even in patients who you suspect has been overdosing on something or has some kind of poisoning, you'll first address A, B, and C. And you look at the vital signs, blood pressure case, heart rate case, respiratory rate case, and it's important for any presentation, but with poisoning especially, two very important vital signs, temperature and glucose. भनेको point of care glucose अथवा चाहिँ हामी के random blood sugar भन्छौँ नेपालमा अथवा पिन प्रिक गरेर ग्लुकोमिटरले मेजर गर्ने blood sugar चाहिँ it's very fast and it gives you a lot of information and you have like some potentially treatable conditions there. त्यसपछि अर्को भनेको चाहिँ in any patient who is not responding to you, you look for like we said, we look for vital signs. If their breathing is depressed and if you have suspicion for and if they are like unconscious, you should think about, should I give this person naloxone, which is an antidote for opioids? And we know Nepal पनि opioid crisis ठुलो नै छ भनेको opioid poisoning भएर opioid intoxication भएर आउने रिस्कहरू धेरै नै छ especially given tramadol चाहिँ is over the counter drug and it is an opioid, it can cause opioid intoxication, so we have to keep that in mind. अर्को चाहिँ अघि मैले भने ग्लुकोज मेजर गर्ने र ग्लुकोज हाइपोग्लाइसेमिक छ भने चाहिँ you have to administer dextrose and try to give these two things to see if that will help with the patient's conditions. These will be the first few things that we'll think about. So is this person breathing okay? Is their airway intact? Are they breathing okay? What's their circulatory status like? Are they in shock? And then also like all the vital signs, temperature and glucose, and try to treat these conditions.
Good.
Okay. Anything else, Pranav? यसमा के भन्नु छ र छैन नि?
छैन. I think most your using slide most important होला overall poisoning because for emergency care because we deal with undifferentiated emergencies.
So when a patient presents to you, you don't know that they have intoxicated unless someone tells you that they overdose on something and they bring a bottle. You don't know what happened. This person might be altered because they are septic. They might have meningitis. They might have some other infection going on, or they might have a head injury. So like you said, it is a very undifferentiated condition, and you will have to try to see if you can treat reversible conditions, and also have a basic approach to all kinds of emergencies. भनेको सबै जुनै पनि पेसेन्ट आफूसँग आइपुग्दाखेरि चाहिँ एयर ब्रिदिङ सर्कुलेसन, भाइटल साइन्स अनि ब्लड ग्लुकोज हेर्ने भनेर प्र्याक्टिस बनाउनु पर्छ। र अब पोइजनिङ अथवा चाहिँ इन्टोक्सिकेसन सस्पेक्ट गर्ने हो भने चाहिँ त्यसमा अब हामीले यो कुन चाहिँ प्याटर्नमा फिट हुन्छ, कुन चाहिँ पोइजन अथवा चाहिँ कुन चाहिँ इन्टोक्सिकेसनको प्याटर्नमा फिट हुन सक्छ भनेर हेर्नलाई ट्राई गर्नुपर्छ। किनभने युजुअली तिनीहरूको ट्रिटमेन्ट सिमिलर हुन्छ, अप्रोच सिमिलर हुन्छ, र त्यसलाई चाहिँ हामी टक्सिड्रोम भन्छौँ। अनि अब टक्सिड्रोम्सहरू डिफ्रेन्सिएट गर्नलाई चाहिँ we have to have certain things in mind. Obviously, vital signs. We'll look at some toxidromes a little bit later, but obviously look at the vital signs. Look at the mental status. Is this person depressed? Like I said, like if they have opioid intoxication, they might be depressed. They might have depressed mental status. भनेको चाहिँ GCS-हरु कम हुन सक्छ, अनि oriented नहुन सक्छ. They might not respond to you. They might even be comatose. Or on the other side, certain toxins or the certain poisons will cause them to be agitated. For example, if they just had cocaine, which may not be common in Nepal, but there are some there are many drugs which can cause agitation or delirium, and you'll see those kinds of patients. And always examine the skin, and a good way to examine the skin is to examine the axilla. And when you talk to a toxicologist or like a specialist who deals with these conditions, they will tell you that you always need to examine the axilla. And the reason for that, किन axilla examine गर्ने भनेको चाहिँ normally in an average person, the axilla is usually moist, but if the axilla is dry, then you suspect that this person has been exposed to something that will decrease sweating. And we'll talk about what those toxins might be. For example, I could just tell right now, anticholinergics can cause decreased sweating, and whereas sympathomimetic poisoning can cause increased sweating. अनि एक्जेला एक्जामिन गरेर चाहिँ you can just get an idea. And you'll always obviously look at the pupils. You'll see if they are dilated or constricted, and if you'll see what their reactions are. They reacting to light? And if they're asymmetrical, if they're asymmetrical, you'll suspect something else. For example, if you'll think, oh, did this person have an intracranial bleed, versus was there some trauma? And you'll try to figure out if they have been having increased bowel activity, as in like they're having loose stools, versus if they're constipated. And we'll talk about all these conditions and what might lead to what effects, just for fun. So when you're like thinking about a patient who has some poisoning, you get a tox specific history. Ask them about herbal medications, over-the-counter medications, prescription medications. Try to, if this person is talking to you and if they can tell you the names of the medications, it's probably good to get a list of all the medications, because they may have, most likely they overdose on medications that they already have at home. And also ask them about their alcohol intake, how much they drank, if they can tell you, or any other illicit drug use, or even like in the context of, let's say, medicines like tramadol, it may be intentional or unintentional, but do ask them if they are taking that. And in the US or like in many other countries, these medicines are prescribed in pill bottles, whereas नेपालमा हामीले थाहा छ त्यसै औषधिहरूको blister pack जस्तो हुन्छ। अब त्यो घरबाट कसैले लिएर आएको छ भने you can just have a look at them. And I don't know if you guys use pill identification tools. I don't think they're really helpful when we're talking about medicines in Nepal, because these tools are designed for medications that look a certain way. I think, for example, US मा अथवा Australia, UK को लागि भनेर त्यसरी डिजाइन गर्नु हाम्रो medicinesहरु चाहिँ they don't fit those descriptions, so it may not be useful, and we don't even need them. Yeah.
Good research topic.
Yeah, it could be potential good research topic. So anyway, like in any emergency, the first hour is very important. And in toxicology, or like in patients with poisoning, you should have a goal to have an idea of how to treat this person, start decontamination within the first hour. And the first hour is you could say it's a long time when you're like looking at just one patient, but it's easy to go by. You just had a patient and you sent their labs and you're kind of like still thinking about the patient, but you get a lot of other patients in the meantime. It's easy for the first hour to just go by, and yeah, you might lose your chance to just reverse the potentially reversible conditions. So toxidromes, basically, we talked a little bit about this. Sympathomimetics, for example, very common ones in the US at least are cocaine, methamphetamine, whereas antimuscarinics, we can talk about first generation and antihistaminics have a lot of anticholinergic properties. For example, diphenhydramine, chlorpheniramine, and it's important to remember, like, many of these medications are present in our over-the-counter cough and cold medicines like Sinex, Decold, present पनि हुन्छ. And sedative hypnotics, for example, benzodiazepines, and the examples would be diazepam, clonazepam, lorazepam, alprazolam. All of these are like easily available, very commonly used. We talked about opioids. It's very controlled in Nepal, but at the same time, tramadol is available over the counter, and it is an opioid. It has all the same opioid effects. It can cause opioid intoxication, and there is also this crisis of illicit opioids that are available in the street, and there are a lot of people who are who have the opioid use disorder. And cholinergics, so that is organophosphates, and it's one of the most common poisonings in Nepal, and we still keep seeing patients with organophosphate poisonings. So this slide is a very important one, and this will kind of help us decide what kind of poisoning this patient might have. For example, like when we talk about anticholinergics and sympathomimetics, a lot of things are similar. These patients will have tachycardia, and they will have high temperature, but and they will also have dilated pupils. But what can help us differentiate, like I said earlier, is with anticholinergics, these patients will be very dry. If we do the tox handshake, if we examine the axilla, whereas with sympathomimetics, these patients will be very sweaty. They will be very wet. An important thing, with opioids, these patients will have pinpoint pupils and everything will be depressed. They will have low heart rate, low blood pressure. They will be not breathing as much. They might have like really low breathing rate, or they might be just apneic, and they may be hypothermic, and they may be dry. And if you listen to the bowel sounds, they will be depressed as well. But with cholinergics, they will have pinpoint pupils, and they will have decreased heart rate and blood pressure. They will have decreased respiratory rate, but they will be diaphoretic, and they will have increased bowel sounds. Sedative hypnotics, most of the things are depressed. And I think Rajesh said sulfos, aluminum phosphide as well is a very common poison in Nepal. Thank you, Rajesh. I don't know a lot about aluminum phosphide and what the poisoning might look like, but thank you. I think that's very useful to know what's common in Nepal. So
I have a question.
Yep.
Rajesh, do you mind talking about aluminum phosphide poisoning? Just to kind of enlighten us, because I have no idea about that.
Hello, thank you. So I think I've seen many patients in our emergency department with aluminum phosphide poisoning. It is mainly used to kill cockroach, bed bugs, and also to preserve rice. And it's very commonly found over the counter in agriculture shops or something like that. So, and also one of our, I think, recent graduate from our Institute of Medicine who recently completed psychiatry had also done suicide using cell phone. So it was kind of very commonly used, and also I think there is not very proper treatment for sulfose poisoning. So once someone consume it, then it's almost sure 100% sure death, because I think it inhibits the electron transport system, and I don't know exact mechanism. I need to see it, but I think we don't have a very good treatment for it. But with organophosphates, I think the prognosis is very good.
Thank you, Rajesh. I think it's an important point, and Pranav might be able to add a little bit, and Jenisha might be able to add a little bit to it too. But in Nepal, one of the common things, first, it's still like we're still a very agricultural country. We use a lot of chemicals in our fields, and it's very common to get poisoning from those chemicals intentionally or unintentionally, and that's one of the reasons why organophosphates have been traditionally a very common method of trying to commit suicide versus also getting accidental poisoning. And we've heard of rat poisons being used for attempted suicides. And thanks, Rajesh, for sharing about aluminum phosphide. So what is already available in the house is the most likely chemical people use for trying to commit suicide or trying to self-harm. And I think it's really important to know that some of these don't really have any good treatments, but at the same time we'll be doing our ABCs when they arrive. We'll be trying to treat the reversible conditions, and we don't know for sure. If we don't know for sure that these patients consume those products that have these really serious effects where nothing is reversible, then we'll be trying to fit them into a toxic room. We'll do our general resuscitative measures in the emergency department. And decontamination is in our context, in the Nepalese context, we are mostly talking about these chemicals, fertilizers that have that the people have been exposed to. So we'll be talking about we should be cognizant about getting their clothes off, cleaning them, washing them, giving practically have to get a complete shower in the ER. And gastric decontamination or intestinal decontamination is done by giving so we could do it in various different ways. I think I have a different slide, and I'll tell you about it. But and serum decontamination practically means dialysis. So there are different ways to clean the eye if they have been exposed to chemicals in the eyes. And there's a specific equipment called Morgan lens, but that may not be available everywhere. So an easy way to do that is to connect a nasal cannula to a normal saline bottle, and you can just irrigate both the eyes with normal saline through the nasal cannula. And you have to do it over several minutes, like 20 minutes, 30 minutes, or maybe even an hour, depending on the exposure, depending on how the patient's feeling. We have different versions of local anesthetics, topical local anesthetic that you can use in the eye. And we have in the US, we have proparacaine. I don't exactly, and you will apply that to the eye and then use normal saline, and you'll try to irrigate until this is the theoretical thing, until the pH is neutral. But I have a question for everyone. Do you know, or maybe Rajesh could tell us, I don't know if this is showing up as an active poll where you can type on your Slido. Is this showing up for you guys?
I can see the slide if that's what you mean.
Oh, no. I don't know if people joined, but I asked people to join on slido.com, and then maybe this is a good spot to start. If I can have.
Yeah, I can see it. I don't know about the others. I think everyone can see it.
On slido.com?
I can see it on slido.com, yes.
Okay, thank you. Rajesh, can you chime in? Do you know? Okay, someone is typing. And there's no wrong answers. You can type anything you know about, because this question is asking you what like are you familiar with? Okay, ketorolac. Yeah, ketorolac is an eye drop. Lidocaine drops. Can we use lidocaine? That's really interesting. That's an interesting question. I think probably yes, if your lidocaine does not have a preservative. Yeah, honestly, I don't know the answer to that. I think we do have lidocaine gels, and maybe we could use that potentially. Lidocaine should not have any toxic effect on the eye, as far as I can tell. But there, like the slide I showed you earlier says proparacaine eye drops, and yeah, exactly. Tetracaine is from the lidocaine family, and it does एउटा प्रिपरेसनै पाइन्छ tetracaine eye drops भनेर. That is one of the commonly available ones. I think tetracaine is available in the pharmacies in Nepal. As far as I recall, I have purchased tetracaine in a pharmacy in Nepal. So that may be something you want to try. Tetracaine eye drops are like, I think, available in small vials. So that may be something you can ask at pharmacies. Okay, I saw so now I can tell who Santo's iPhone is. Thank you, Santo's type. So I can see a comment. Hazmat and CBRNE requiring decontamination process may have different approach to usual isolated poisoning and overdose. Poisoning with 1 to 3 approach will trigger CBRNE. So Santosh, can you tell us what CBRNE is? I'm afraid I'm not really familiar with that term. So in this entire presentation, I omitted a slide where we talk about like skin decontamination and different levels of decontamination. And I think that's what Santosh is talking about here. So depending on what kind of chemical you think the patient is exposed to, you will have to use personal protective equipment, trying to like match the level of the risk from the contaminant on the patient's like body surface or skin surface. And that is graded as like level 1, like personal protective equipment, level 2, level 3, and level 4. And like the highest levels will have to wear what we call hazmat suits, you know, the kind of suits that we used to see people wearing, the first responders wearing during the early days of COVID pandemic. So that is like complete body protection. In a hospital, what you'll usually use is just masks, gowns, and hats and gloves, just to make sure you're not exposed to the chemicals that the patient has been exposed to. And I think that's what we're that's the slide I omitted. So you can see hazmat suits and practically how you may have to scrub the patient just to clean their skin. And there's different ways to decontaminate the patient's gut or gastric decontamination. Earlier, like traditionally, we used to hear about ipecac and gastric lavage. We don't do that anymore. Instead, like for a lot of conditions, we can use activated charcoal, and it is available in the pharmacies. And it like you have to dose it based on the patient's age and weight. But an important factor to consider is that you can only administer activated charcoal for certain specific conditions, and only for people who are like alert and can take it by a mouth, because that is the only route you can administer it. But you would hold off on administering activated charcoal for patients who are unconscious for the risk of aspiration. And whole bowel irrigation is a concept that is important for patients who are like, we talk about this in the context of what we call body stuffers or body packers, people who have swallowed like certain like bags of drugs, let's say like usually typically enclosed in a condom or like a plastic bag, and they are just transporting those drugs, and they're at risk of getting exposed to high doses of these drugs if these carefully packaged bags like rupture inside the intestine. And this is how a lot of drug smuggling happens. And we may not like see this typically in Nepal, but it's important to keep in mind that that's a thing. And for these people, we talk about whole bowel irrigations, and what PEG-ELS is. It's available as Peglic in Nepal, and it is polyethylene glycol. It is a laxative. You have the patient drink large amounts of this laxative, like maybe 1 to 2 liters, even more, and you have and they will have a lot of bowel movements, and finally you can see that they're just having bowel movements from the laxative, and they don't have like any other like intestinal contents. That's what intestinal decontamination is.
Question: Is it the lightly that we use to prepare?
Yes,
for
exactly. Yeah. In the US, it is available as Go Lightly. It's available as Piglic in Nepal.
Okay, thank you.
Yep. And decontamination of blood for certain chemicals that the patient has been exposed to. And typically the example is aspirin and methotrexate, and also lithium that's used a lot by a lot of patients in Nepal. And it's very, very nuanced, and you would probably not be making this decision by yourself, but you have to think, oh, is this patient going to need dialysis? And aspirin is not a common poisoning in Nepal, but people may have taken aspirin, and methotrexate may be one of the drugs that you'll see, but also certain metals, certain antibodies. Oh, sorry. My bad. Let me go back. And so dialysis, typically chemicals like lithium or aspirin again. For certain drugs, you might want to alter the urine pH. That is known as ion trapping. And aspirin may be a drug that you want to treat like that. Aspirin poisoning, you want to give them sodium bicarbonate so that the urine is alkaline, and you are increasing the excretion of aspirin. Methotrexate toxicity can use the same approach. For certain various like heavy metals, you will use antidotes called chelators or chelators, whatever you want to call it, that will bind to that heavy metal and remove it out of the system. And we'll talk about some examples. And for certain kinds of poisonings, you can use antibodies. And one of the biggest examples is digitalis or digoxin toxicity. And for that, there is a specific antibody called DZ-FAV or DZ-bind, depending on where you work and what your institution's practice is. And that may be available. Okay, so there's going to be another quiz, and it says that only that's me. Let's see, let me launch the question. Which of the following can be cleared by dialysis? And I'm sorry, it's only for 20 seconds, and if you don't have the time to answer, it's okay. We got one response. Okay, great. Yeah, so yeah, whenever you see in multiple choice questions, whenever you see all of the above or none of the above, maybe that's one of the answers. And yes, lithium, I know I said that it is, you can typically clear it by dialysis, but some toxic alcohols like ethylene glycol or methanol poisoning, you may think about having to use dialysis. And also for aspirin, like I said, you may think about having to use dialysis. So let me go back to comment in the chat. Dr. Santosh says 1 to 3 approaches when single patient arrive in the ED treat like poisoning. 2 patient patient will trigger some concerns, 3 patients or more will trigger hazmat. This was exactly what happened in recent poisoning case with Novichok poisoning in the high-profile persons with several collateral victims. Okay, so if a single person is arrived, we just treat them like poisoning. If 2 people arrive, it will trigger some concerns about whether this is, I think we're talking about a mass exposure, and 3 patients or more will trigger a hazmat response. So you'll have to so hazmat is like the name of the suit, and I think it's probably like an approach as well. When you'd have to think about mass poisoning cases. So I mentioned some heavy metals that can be treated with some other antidotes that we call chelators. And this slide was supposed to ask you what the chelators are for, which heavy metal. But so we know that iron, we have deferoxamine for lead and arsenic. There's something called dimercaprol. EDT is available, and we know penicillamine is for copper. And interestingly, like for the most part, for iron and for lead, you may probably use these antidotes, but for copper and arsenic, like these are like sort of chronic poisonings, and you will probably like admit the patient or talk to someone else before thinking about using these chelators. We know that snake venom is a poison, and there's ways to treat it. We know that anti-snake venom is available in different parts of Nepal, and I mentioned Dizifav or Dizivind, and that is an antidote for digoxin. Oh. And once you have taken care of the ABCs, once you've thought about what toxidrome this patient might have and what treatments I might need to give them, you should think about what labs you will usually send. And in places where you'll obviously send like a complete blood count, renal function, electrolytes, and you'll send ethanol level, and you'll probably also send paracetamol level, because it is a commonly available over-the-counter drug. It is a silent poison, like intoxicant, and people may not have clinical symptoms of paracetamol poisoning, but it may slowly be brewing up in the patient's system, and they may be chronically exposed to this. And this is usually a kind of poisoning that accompanies other like poisoning that is manifesting itself. You may want to send salicylate levels, but it's very commonly used in different other countries. But in Nepal, I don't think people take aspirin as regularly, so it's probably okay to not send that level. And I wanted to talk a little bit about urinary toxin. It may not be available everywhere, but it's also not like a very specific to acute poisoning, and it has a lot of false positives and false negatives. So it may not be really useful in the acute setting. But you want to see liver functions, you want to see INR. If the patient has been, if the patient was exposed to certain poison and has been on the ground for several hours, we usually want to look at creatine kinase. And for specific situations, you might want to look for serum osmolality and drug levels and ammonia as like I said, as directed by specific ingestions. We can talk about them in a little bit. So you will want to see if this patient has electrolyte abnormalities. You want to correct them if they are present. And you will also want to see this patient's acid-base status, and you may want to think about certain poisons when you see certain abnormalities, like let's say, for example, non-anion gap metabolic acidosis, and you know a whole list of conditions that can cause non-anion gap metabolic acidosis. If the patient is altered, and we said like we should probably send ethanol level, but you can also ask the patient and the family if that's what they drank, like just ethanol, or if there's a risk of contamination from other toxic alcohols, typically methanol in Nepal. So I'll ask you guys to join the Slido, and then I will launch the quiz. I have slido.com 3769638. Okay, there's 4 people who have joined. Okay, and let's see. Great. Yes, so all of the below. Methanol poisoning can cause blindness, it can cause respiratory failure, and it can cause kidney failure. And thank you for your responses. Like I said, we should send paracetamol levels for all patients, but salicylates usually produce symptoms. And salicylate means aspirin, acetyl salicylic acid, typically we order that with paracetamol levels in the US, but probably not in Nepal. I talked about the caveats of urine toxicology. It does not represent acute intoxication for the most part, and people may still test positive because the chemicals may still be getting through in the urine for several days to say, up to like even weeks. And there's so many false positives. There's so many false negatives, especially when we're talking about synthetic opioids like fentanyl, which is a very common poisoning among like people with opioid use disorder these days. And all benzodiazepines are a common poisoning, and we may miss that with the urine toxicology. So I have a question in the chat. It says, how can methanol, I think we're talking about methanol here, how can it cause respiratory failure? Yes, thanks, Pranawa, for answering that. So yes, it is, all forms of alcohols are respiratory depressions, and yeah, GABA-mediated respiratory depression is probably the right answer. And we'll send hepatic panels for poisonings like paracetamol poisoning if the suspected toxin is hepatotoxic, or if we see stigmata of liver disease, if the patient has a known history and is altered. In those cases, we would send the hepatic panel. And for patients who are suspected to have stigmata of liver disease, you want to send ammonia label. But interestingly, valproic acid intoxication also causes elevation of ammonia, and valproic acid is a common antiseizure medication used by a lot of our patients in Nepal. So we have to think about sending an ammonia label in patients who are altered and suspected poisoning. If the patient, like I said, was found down to catch for evidence of rhabdomyolysis, you could send total creatine kinase label, but you can also maybe sometimes detect rhabdomyolysis, evidence of myoglobinuria in the urinalysis. And you can, for certain drugs, drug labels are available, but these don't come back right away, so may not be really helpful. But you could think about sending drug labels for digoxin, phenytoin, valproic acid, and things like that. Okay, I have a question for everyone, and maybe it's in the next slide, but you will send an ECG, you'll get an ECG for all of your patients who are suspected poisoning or suspected overdose, and specifically you're looking at the AVR lead and the QRS you should look at PR, QRS, and QT intervals, and some poisonings cause QT prolongation, also like specifically QRS prolongation. But on this slide, we're looking at AVR, and we're talking about how in AVR typically we don't see this big R wave that's wide and that's bigger than the S. Our S ratio is more than 0.7. I think the next question is, get ready, everyone. So what toxicity causes terminal R wave in AVR, or like that big prolonged R wave in AVR? And this may be a difficult question. It's okay if this is wrong. Wow, congratulations, everyone. That's great. Yes, tricyclic antidepressants for typically like the common names for tricyclic antidepressants that we use in Nepal, amitriptyline and imipramine. So those are the two very common ones, but there's a whole list of medications that is like prescribed very frequently and readily available, and it can cause a lot of other things, including this terminal R wave in AVR, but the typical response you'll see is QRS prolongation, and that is the correct answer. A lot of times you might want to look for you might want to get some imaging. Let's say, for example, you might want to get a chest X-ray to look for signs of aspiration, or sometimes you don't know whether this patient has some kind of poisoning versus some sepsis, and you want to look for a focus of sepsis. Then you might want to send a chest X-ray. A lot of times, if you get an X-ray, foreign bodies may be seen. If the patient has like consumed heavy metals, you can see them in the radiographs. And speaking of specific imagings, head CT should be ordered based on patient symptoms. Like I said, if you do not know if this patient has a stroke, head bleed, versus if this patient has some kind of poisoning, then you probably think about getting a head CT as well. And there is a whole list of medications that may show up in the radiograph, but if they do not, that does not mean you can rule this out. Okay, now the question: what is the antidote for tricyclic antidepressant toxicity? And I think we'll get a lot of correct answers in this one. Antidote for tricyclic antidepressant toxicity. We got 4 responses and all of them are correct. Congratulations, everyone. Yes, sodium bicarbonate is the antidote for tricyclic antidepressant toxicity, and you'd want to use that. Congratulations, Dr. Santosh. You want to use that for people with tricyclic antidepressant toxicity who have QRS widening typically more than 100 milliseconds in the EKG. In one specific thing to keep in mind is, like, for a normal patient who is not suspected overdose, the normal QRS is less than 120 milliseconds. But for patients with suspected poisoning, you want to keep the QRS 100 or below. So even though normal limit is less than 120. Naloxone, we know that, we all have heard of naloxone. Many of us have used naloxone. It is an antidote for opioids. Important thing to keep in mind: it is a lifesaver. It can change the patient's breathing status like really quickly, within seconds. And it can cause pulmonary edema and opioid withdrawals, but if the patient is dying, you'd probably not worry about that. You would probably give it. Flumazenil is an interesting antidote for benzodiazepine intoxication. A lot of times benzodiazepines can cause respiratory depression, but we don't like to use flumazenil because it can precipitate seizures, and it can also precipitate benzodiazepine withdrawals. And the treatment for benzodiazepine withdrawals and seizures is again benzodiazepine. And if you give the patient flumazenil to block the benzodiazepine receptors, your treatment is not going to work. So instead, like in patients with benzodiazepine overdose, what you want to do is you can give them supportive treatment. If they're not breathing well, you just intubate them, give them respiratory support, and you let the effects of the drug wear out, and the patient will gradually improve on their own. So where to get them from the ER? A lot of times you can watch them, you can admit them for a couple of days, and then or maybe just for over 24 hours. Many of these patients may be able to go home within usually 6 hours. Typically you watch them for 6 hours if they're not severely intoxicated, and they can go home. You admit them if they are still needing supportive treatment, IV drugs, IV fluids, and things like that. And typically it's for observation. But there's a list of medications that can cause prolonged toxicity, and you want to watch them for like over 24 hours. And in this list, I think the most important one is sulfonylureas, very commonly used for diabetes these days. And the second generation sulfonylureas have been found to cause prolonged intoxication and delayed hypoglycemia as late as up to 24 hours. And the typical standard recommendation these days is to observe them for more than 24 hours before letting them go home. So if the patient is agitated, you know they may have taken something, but you don't know what exactly. And if they are like, thrashing around the ED, they're threatening to hurt you, they're threatening to leave, then, and you think this patient needs to be sedated for the safety of the patient and for the safety of everyone who's treating the patient. The typical approach used to be that you used to give them haloperidol, Benadryl, or diphenhydramine, and lorazepam, or like a benzodiazepine and haloperidol, like whatever combination we used to give before. Nowadays, we know that these patients probably do better with just midazolam. It's very commonly used, it's very easily available, and if you do not have an IV, you can give 4 to 5 milligrams of midazolam IM, and this patient will be fine. The worst, you may have to intubate them for respiratory support, but that's probably not going to happen in an adult of a standard size. So 4 or 5, our typical vial of midazolam in Nepal is 5 milligrams. It's 1 milligram per ml. So you'll give 5 ml in the patient's like muscles, like just deltoid or gluteal muscles. You may want to have like 3 or 4 people to hold them down and just administer it. And after that, you may think about giving them an antipsychotic, for example, olanzapine. Okay. Yep.
I have a for Pranay and Subhan.
Yeah.
ED now we are so concerned about like prolonged QTC as an internal medicine doctor. Do you guys ever worry about prolonged QTC?
Yes, we do worry. We do worry about prolonged QTC, and we don't like to give certain drugs if we know that this patient has prolonged QT intervals. But I think your question is like you don't want to. Is your question that you don't want to give certain sedating drugs when the QTC is prolonged? Is that what you mean? Is that what you're asking?
Right. Let's say if a patient walks into the ED, EKG got the QTC prolonged, but if that patient is really agitated and you want to give Haldol, would you go ahead and still give them Haldol, or would you just like give?
Yes, yeah, that's a very good question. So Haldol, we know if you administer IV, then it does have prolonged QTC. It can precipitate arrhythmias in a patient with prolonged QTC interval. Whereas we know that if we administer IM for whatever reason, if it is administered IM, it is probably very safe, and you can like give it IM if you are worried about a prolonged QTC interval, and it's supposed to be safe. So you don't really or yes, Pranav, sorry.
You can also use benzodiazepines, and then if it comes to push comes to shove, I'd rather have a prolonged QTC rather than a person who is trying to hurt half of my staff. So I think ED emergency management most of the time is about balancing act. Most of it is. So if there is frank prolonged QTC, then probably best to avoid Haldol and then antipsychotics.
Yeah, so our standard approach, like what I was trying to say earlier, we want to give benzodiazepines when you probably want to give midazolam, and that the reason for that is you don't want to give Ativan or lorazepam because the effect is delayed, and in this agitated patient, everyone wants like quick effects for one, and if the effect is delayed, there's a risk that you may give them more, and we call that benzo stacking. If the patient will have received a lot of benzodiazepines by the time they are actually sedated, and they probably didn't need all of that, and the reason for that is you give them a slow acting medication. So you want to give them a medication that will just have a prompt response. The reason we don't want to give them Benadryl or diphenhydramine if they're undifferentiated is we don't know for sure what kind of toxin or what kind of like poisoning this patient has been exposed to, and some of them can make them hyperthermic, and hyperthermia is really dangerous in these patients. And the reason we don't want to give haloperidol in the beginning itself is we don't know for sure if they have prolonged QTC, because this patient is not going to lay down for you to get an EKG, and if you already have an EKG, that's probably fine. But QTC prolongation. So if it is like Pranav said, if it's like absolutely prolonged, and we worry about it when it's like 500 or over, then you don't want to give haloperidol, even though like the alert is like for any prolonged QTC, you don't want to give it. And when you're like in a position where you have to give it, it's safer to give it IM. We know from like data that it does not probably cause and with QTC interval prolongation, we're worried about like precipitating torsades in these patients, and it if you give it IM, it probably does not cause that. So that's a common known thing. And Dr. Santosh may be able to chime in a little bit more in this because it's a very nuanced topic.
Yeah, thanks. So as Pranav mentioned, ED is a balancing act. We normally talk about what is going to kill the patient first. When the patient is agitated, you also need to think what is going to kill the staff first. Yeah, I would probably go with the benzos first if you do not have EKG. And agitated patients, you have rightly mentioned, it is very difficult to get EKG in an agitated patient. Most of the time, there is a cause for agitation. So it may be mental health, it may be drug overdose, or it may be simply that the patient has some other form of issues, like if the patient is in too much of pain, they may be agitated. Those kind of things you need to think about. Haloperidol of 2.5 IM, even with the high QTC, I have given in my clinical practice. But for beginners, I would probably caution, because yes, haloperidol can cause some has artemisinin properties, and you don't want to give it in somebody who has QTC. So you have to work both medical legally, as well as sometimes in the beginning of your practice. Most people are. I am comfortable now giving haloperidol in long QTC. That doesn't mean this is a safe practice. So for beginners, I'll probably avoid haloperidol if you are concerned about prolonged QTC. But yes, benzos, it is safer for that purpose. Can I just tag two things?
Sure,
so
yeah.
Having agitated patient and poisoning, so these two have to be separated. Okay, most of the time we think that agitated patient is either taken some kind of overdose or recreational drug, or they have a mental health problem. Okay, probably 90% or probably 95% of the time you are right. 5% there is an organic cause. So because the problem is, yes, if you put somebody as a overdose of some recreational drug, that is fine. But once you put a mental health tag on that patient, that remains with that patient for life. So any agitated patient, we just have to be careful to rule out any form of organic causes. So my recent case was the patient actually had a intracranial lesion, so has a kind of astrocytoma. He was behaving very, very agitated. We have to sedate, and we scanned him, and we found that there is a mass. So before labeling somebody as a mental health, we just have to be careful. But yes, poisoning, overdose with some sort of recreational drug, agitation is one of the presentation coming to A&E.
Thank you very much. And I think that's a really good point. Not all agitated patients have mental health problems or have been intoxicated. They might have a serious underlying medical condition that actually needs treatments other than just sedating them and just making them quiet. I think that's a very important point. For those of you who don't know, and this is the first time I'm interacting with you as well. Dr. Santosh Pradhan is a graduate of IM 16th batch, if I may introduce you, Santosh. And he is an emergency medicine physician currently practicing in the UK. And I think we have a good combination of physicians from Nepal, like Rajesh, and we are Pranawa and I and Jenisha were in the US, and we have a lot of like participants from Nepal. So I think this is really wonderful discussion.
Thanks. Thank you very much. Thanks for introducing me.
Of course, thank you very much for joining. It's our pleasure. I have so if anyone has any questions, you can ask them now. You can also post them in the chat. But I have a few questions that people in Nepal probably need to know about, and maybe Rajesh can provide us some answers for some of these. Rajesh, do you know if IV and acetylcysteine is available in Nepal?
I think yes. I'm not quite sure. Maybe somebody that I may answer it, but I think I've seen N-acetylcysteine IV during my emergency posting. So
Great.
I think yes.
Yeah. So for I mean, most of us probably know N-acetylcysteine is the antidote for paracetamol poisoning, and it is one of the really effective drugs we have. One of the effective antidotes, and there's a lot of different nuances as to when to use it, but it is something to know about and be familiar with. And again, always the burning question: what is the most common poisoning in Nepal? I want to say it's probably still opioid poisoning. Sorry, organophosphate poisoning. Any other thoughts? Anyone else thinks any differently? Again, Rajesh, are you able to answer that question? Do you know?
As far as I know, I think organophosphate is the most common and easily available. So it's most common poisoning in Nepal.
Yeah. It's been very common cause of poisoning for a long time, and therefore we kind of have to be familiar with how to treat organophosphate poisoning. We'll be encountering this in all the primary healthcare centers, all the emergency departments that will probably work after MBBS graduation.
Can I ask one question?
Sure.
Is poisoning a reportable case in Nepal? So probably this question is probably for Rajesh.
Yeah.
Is, as let's say, for example, somebody comes in with a poisoning of, let's say, paracetamol, and somebody comes in with a poisoning of organophosphate. Because I know when I was there back in 2004, organophosphate poisoning has to be reported to police. We did not see much of a paracetamol or aspirin or any other kind of prescribed medicines poisoning back then, but I'm not sure what is the current status now.
During our emergency posting, yes, every poisoning must be recorded, and it's a medical legal thing. So it will be reported to the hospital police. We have a unit of police in our own hospital. So I think every hospital or district hospital may have it, so that we can report such medical legal issues to the police. So I don't know much, but I think it will be reported too.
In that case, the question of what is the most common poisoning in Nepal, I think the answer will be, it will be recorded as such, whether it is organophosphate or paracetamol or something else. The other issue, what I found when I was practicing back in 2004, was not all poisoning comes to A&E. So this is something we probably need to bear in mind. So some of them are deliberate poisoning, but some of them are accidental poisoning. So for example, somebody has, the typical example was a dental pain. People who have experienced dental pain, you will know whatever painkiller you take, it doesn't work. So patient normally takes one after another painkillers with a different brand name, and they do not know it also has a paracetamol. Some will have paracetamol and codeine, some will have paracetamol ibuprofen, and they will take at least 3 or 4 cocktail of paracetamol containing medicine. And they trigger the typical of 12-gram limit of paracetamol in 24 hours. Not all of them come to A&E. They sometimes comes to, I mean, in my days, I'll still say 2004 or before, 20 years ago, they do come to a clinic with signs of liver injuries, liver failure, signs of liver injuries. But that by that time the damage is already done, and during those time that was a very difficult time. We do not know what is the medical legal, because it is not a deliberate one, it is accidental, and that those cases were not reported and recorded as such. Things may have changed by now.
Yeah, I think Samriddha is also one of the physicians from Nepal, so he may have an answer to that as well. But yeah, I couldn't tell you. I don't really know. It's good to know that like some poisonings in the ER have to be reported. But yeah, like I said, the police may have some records of you know, if they found these patients in their houses, if they were already like, you know, if a death had occurred by the time like someone responded and it was reported to the police, they may have records of that. But I don't know what the data would be like for patients presenting to the clinics, unless they were like then referred to the ER and the ER reports it.
So I think the more interesting question will be, what is the most common lethal poison in Nepal? Which poisoning ends up in death? Which poisoning we are better off having a live patient, and which patients are actually dead? So
yeah,
the data may be from police record and mortuary.
Yeah.
And I mean, it's very easy for me to say from here, but people who are working in Nepal, they may have some links. It may be a good topic to do a kind of a small audit or a research in itself to say that.
Yeah.
Because you may or may not know, in the last 2 to 3 years, because of COVID, the mental health cases has gone high,
Right.
more than 30%.
Mm-hmm.
Up. The reported cases of mental health has gone up, and the reported cases of poisoning has gone up significantly. So this may be a good project for the doctors who are working in Nepal emergency medicine, emergency department to do a small audit and research to say that what is the most common poisoning in Nepal and what is the most common lethal poison and what is the data source.
Yeah, and that's one of the reasons I wanted to put out this question, because if you're working in Nepal, it's probably important to know what you will encounter and what people commonly die from, and that's why I wanted to trigger this discussion, and I think it's a very wonderful discussion. Thank you everyone for participating, and especially thank you Dr. Santosh and Rajesh for answering so many questions. Few other questions, and these may be topics to research at home as well. Again. We know that we have anti-snake venoms. Do we use them for all snake bites? When like where are we getting them in Nepal? Like I know the different centers in Nepal, for example, district hospitals or regional hospitals will have them depending on their location, but it's probably worthwhile trying to research. If you're going to work in a center, it's probably worthwhile trying to research snake poisoning common there, and or snake bites common there, and is anti-snake venom available there?
So I think for snake venom, as far as I know, one of my relative was bitten by snake. Mm-hmm. And I took her to the local hospital, district hospital which was in Parbat. I took her to Beni Hospital, and unfortunately there were no any snake venoms in Magdi Beni Hospital. Mm-hmm. And I think most of the district hospital in Terai region have snake venoms. Mm-hmm. But in hilly regions and mountain region, only selected district hospital have snake venoms. Like for us, Baglung District Hospital or now Baglung Provincial Hospital had the snake venom, but not in the Magdi District Hospital or in the Parbat District Hospital.
And is it true, Rajesh, that like I mean it's it's not always available even in those hospitals, right? Because you may use, let's say, for example, a patient with snake bite comes there, and you use that use the available anti-snake venom for that patient, and let's say 3 days later, there's another patient with snake bite. So you may not need to treat that other patient. Is that do you think that's possible? Because the supply is limited, is what I'm trying to say.
I don't know. I don't have the
Yeah.
exact
Okay. Yeah.
data
But
about
yeah.
it.
Yeah. No. I'm
But
just yeah.
but okay. But what I know is that not all the patients bitten by snake bites are given snake venoms.
Yeah.
They are like for me, one of my relatives was bitten, and I took her to the hospital. We did PT and BTCT, and we monitor her over 24 hours. So if there was anything wrong, then the hospital would refer me to the Bagong hospital for snake venoms. But fortunately, nothing happened. So we just stayed over the ED for 24 hours and discharged for home.
And I think that's a great point, because we don't have to treat everything we see, right? So not all snake bites are poisonous. Most of them are non-poisonous. And I think what you're saying is some snake bites can cause coagulation abnormalities, and maybe we do have like anti-snake venoms for those that can cause that. It's a very broad topic, and it's a topic for a complete different session. But it's important to know that it's available in some centers. There's a possibility that wherever you end up will refer to a bigger center, and it's possible that your patient may not need that treatment. So it's probably okay to just observe them. And I will not go into details of this, but the dose of atropine in OP poisoning, it's not very limited. You can use a lot of atropine in patients with organophosphate poisoning. They may require a lot of atropine, but you have to remember that is the treatment. Finally, again, like every session, I request everyone to join Google Classroom. It makes it easier for me to send out messages relating to these sessions, and also to share resources. So the way you join is classroom.google.com, and you put in this code WTCAQNU. But I have shared the links for the Google Classroom in all the posts that I've sent out in the social media so far. You can also click join by just clicking that link. I always want to say there are a lot of free resources available. Just make use of these resources. And finally, let me post this link on the chat so that I'm just posting this link. MRAP is a free, it's a paid resource, but it is being made available for free for anyone who joins these sessions, or for all the people practicing in Nepal. And I would like for you to be able to make use of that. And if you are interested in joining, getting a free subscription for MRAP, please just drop your name and email address on this link. And let's see if I have anything else. And that's it. Thank you everyone for joining. And always, questions are always welcome. If you have any questions, we're here for a few more minutes. And if I know Samrita has been posting a lot of things in the chat. He says that we don't report to public authorities just automatically, and maybe only police cases registered. And if they end up in the ER, maybe the ER will report to the police, and that may be helpful. Dr. Santosh, do you have anything else to add for this session?
Nothing for me. A very good session, Sumana.
Thank you so much.
Very well presented.
Thank you. Thanks for participating.
My camera was locked for some reason, so I finally managed to get my camera sorted out.
Right, good to see you.
Yeah.
Thank you, Jenisha. Thank you, Rojak, Rajesh, and Samrita for joining and making this really interactive and really very useful. And if nobody has any other questions or any thoughts to share, we'll just probably end the session.
Thank you. Thanks,
Thank you.
Thank you very much.
Bye-bye.
Thank you. Bye-bye. Good night.
Have a good one. Bye. Bye.